Good evening, everybody. Nice to have you here on this wonderful webinar that we're hosting tonight in conjunction with Hospital Foundation Arthritis with Michelle Kirby, who's joining us from Adelaide to present Continence Challenges when you have arthritis. So I'm just going to do the old housekeeping, which is around making sure you keep moving. Sitting still is not good for anybody. So if you need to stand up, you can still listen and see the screen while you're standing up. Our presenters and our moderators will have audio. So if you do have any questions, we'd love to hear from you. There's the question and answer chat function. You can put your questions in that section. And if it's something particularly relevant, we'll ask it along the way, but we'll save most of the questions to the end. And tonight, I'd like to acknowledge the traditional custodians of the country throughout Australia and their connections to the land, seas, and their community. I'm joining you from the land of the Kaurna people in Adelaide, and I would like to pay my respects to their elders past, present and emerging, and to any Aboriginal and Torres Strait Islander people joining today. And obviously I'd like to pay my respects to people who have traditional lands in other parts of Australia. Tonight's presenters, I'm moving my screen around. So we're welcoming Michelle Kirby, who's a very experienced obstetric and pelvic health physiotherapist, and she's the owner of PFM Physio. Michelle is a continence and pelvic floor physiotherapist, and she received her degree from the South Australian Institute of Technology, which is where I started before it became Uni SA. And now Uni SA will actually be part of the new Adelaide Uni. So we'll have to change our unis again, Michelle. She holds a graduate certificate in community health, and she was awarded the APA titled membership in continence and pelvic floor health in 2008. Michelle's delivered pelvic floor physiotherapy in hospital, community settings, and public and private sectors. And her own pelvic floor practice started in 2002, called PFM Physio. Michelle's an experienced educator, lecturer, and tutor, and has worked with undergraduates and graduate physiotherapists and also educated other health professionals. Michelle has a reputation for being a dynamic speaker, so we're expecting a lot tonight, Michelle. But she does donate a lot of her time to community groups as well as the APA, and we're very grateful to have you tonight. And we've put this one together in conjunction with Ben Trebiani, who's a health educator at the Hospital Research Foundation group Arthritis. And my name's Joanna Lee Tan, and I am the finishing up National Chair of the Gerontology group, and I am a titled Gerontological Physiotherapist. So we're going to have a poll now, and Bridget is working away in the background there. Hopefully this will come up. I will stop sharing. And what we're interested in here, and it's all anonymous, is just to get a little bit of understanding about who's listening to tonight's presentation, and not so much your identity, of course, but your background. And that will help us in understanding who found this an interesting topic, and also where you may be living with issues related to arthritis or incontinence, and how this might be relevant to you tonight. So if you're able to select your answers, scroll down on the poll, and then we'll get the results coming through. Got 30% of our respondents are interested community members, and 70% no, so possibly they could be physios joining us at the presentation. Are you interested as a health professional? Yes, so we've actually got quite a lot there, 92%. Are you living with arthritis? Yes, 18%, no, 82%. Are you living with incontinence? Yes, 18%, no, 82%. And are you a carer for someone? We've got 16%, and no, 84%. So thank you, Bridget, for running that poll.
And the brief was that in our session tonight, we would have an opportunity to consider how arthritis can affect continence, a consumer's level of understanding of bladder and bowel function, who they might be seeing in order to gain help with a continence issue, and some tips and strategies on managing for functional or social continence, and then a question and answer session at the end. Okay, so incontinence can be a transient and acute experience, and so if there is an acute or a transient experience, it's usually going to be a really quick onset of a dramatic change. And these are the sorts of scenarios that might generate a period of transient incontinence. And so whenever somebody has new symptoms, this is the first part of assessment, is to consider, is this a transient acute episode, or is this the beginning of a chronic situation that's developing? So part of an acronym is DIPERS. So we need to consider if delirium, infection, atrophic vulvar vaginitis is to do with tissue changes and irritation in the vulva or the vagina, psychological causes, pharmacological agents, endocrine issues, and or excessive urine output. So health conditions that might be generating an excessive urine output, restricted mobility, and stool impaction. So all of those things in of themselves might be transient causes of incontinence. But if we also look at that list and consider that some of those causes can in fact become chronic conditions. So someone might have restricted mobility short term because they've had a fall or an injury, but with arthritis, they might be facing more chronic restricted mobility issues. So from here, we move on to thinking about what are the arthritis-specific challenges that can impact on continence. So it's primarily going to be a situation of being able to get to the toilet on time. So getting to the right space with your clothes down, sitting safely, or standing safely if you're a chap. And so for people with arthritis and the various challenges they may face with joint pain, stiffness, that may affect their ability to get to the toilet. It may affect their dexterity for dressing and undressing. The other aspect that links back to arthritis is constipation, which may be pain management induced. So when people are needing to use opioid type pain management, then they have got a higher risk of developing constipation as a side effect of that drug regime. The other potential causation for incontinence symptoms might be urinary tract infection, and that may be a sequelae to poor dexterity leading to poor hygiene in the toilet. And so if people are unable to wipe themselves effectively or have had to change their position to reach, then perhaps they've not been able to maintain enough hygiene to prevent urinary tract infection. The other area that is very much a watch this space is the role of inflammation. So we know inflammation is a component of the arthritis pathology, but there are certainly some links with bladder conditions being bladder conditions being an expression of an inflammation disorder or an immunological disorder. So it's an area that I can't comment specifically about, but it's on the watch this space perspective. In terms of what I would like consumers to understand about bladder and bowel function is to be able to have a sense of considering whether or not what you're experiencing would be something to consider as being continent or being incontinent. And so this is, in the next few slides, we're going to contrast sort of benchmarks, if you like, for what you might consider as an expression of continence, bladder function that supports continence, or bladder function that suggests incontinence. Okay, so in the continence part of this slide, in terms of frequency, if someone is having a healthy level of fluid intake, and we'll leave fluid intake as a detailed discussion for later in the session because it's quite a complex area, but essentially if the fluid intake is appropriate for the individual, then they're likely to need to pass urine 7 times a day and 0 to once overnight. So if the experience a person is having means that they are more than 7 times a day, then it may be that that's an expression of incontinence, but in fact it may also just be an expression that their fluid intake in fact is higher than is recommended. So when we think about incontinence as an expression where the symptom is one of frequency change, we have to then interpret with caution and give some consideration to what the fluid load is for the person. But certainly, if the fluid load is not a confounding variable, then someone who has a frequency of greater than 7 in the day or greater than once overnight is potentially got a bladder problem and would therefore be categorised as having an incontinence issue. The second area is about the ability of the bladder to store and the sensation of the bladder when it is filling. So bladders can generally hold, there's variation between individuals of course, but a maximum capacity of about 800 mils. Now that's not something that we would expect to experience in day-to-day situations, needing to be able to hold 800 mils. But if the situation called for it, then majority of healthy bladders are going to be able to do that. What we anticipate is that we would have a sense of fullness at about 400 mils or 50% of our maximum capacity. We would have a sense of being full and a readiness to go to the toilet. But that should be an experience that is comfortable and not an experience we would describe as feeling urgent. Urgency is an uncomfortable sensation of bladder fullness, and that's not something that we would expect to experience in day-to-day circumstances. If we had 800 mils, probably yes, we're going to be urgent. But in our day-to-day living, we shouldn't really experience urgency at all. We should experience a sense of fullness. When people have problems with bladder storage or sensation, sensation would be the urgency symptom, but if they've got a problem with storage, then they may also find that they are having small, frequent voids. So that might contribute to a higher number of voids per day or night. Or in fact, it could be the reverse, in that their bladder is overfilling and they may in fact have infrequent, large, excessively large voids because their bladder is overstoring it. The storage capacity is being exceeded. So those symptoms would also qualify as symptoms of incontinence. The one that most people anticipate hearing about when we hear about incontinence is to do with emptying problems. So continence means that we have the ability to empty intentionally, that when we do empty our bladder, the urine flows to empty without interruption or effort. Incontinence would be unintentional emptying or leaks. And so the leakage experience might be a small volume, or it could be a full emptying of the bladder, so a total void. The other symptoms that can be experienced as a problem of emptying could be pain and or straining to achieve emptying. And some people will have a sensation where the urine flow has stopped, but they don't feel empty. At the bottom of the slide, I've highlighted a bladder diary resource that you can download for free from the Continence Foundation, or in fact, they'll mail it out to you if you prefer snail mail. At the end of the talk, we've got a page full of these references. I've just put it there to remind us that when you're thinking about what's my situation like, then maybe doing a bladder diary would help give you some insights into what's going on for you or for the people that you're caring for. So if we move off bladders and move off that page and look at why might these things occur, these changes or symptoms. They can have local causes, and by that I mean that there is a change in how the bladder itself is functioning, in the wall of the bladder or the lining of the bladder, that there are sphincters to control the keeping urine in the bladder, preventing it from passing through to the urethra. The urethra is the tube that leads away from the bladder. And so this sequence under local describes the process by which the nervous system has to juggle situations so that the bladder can fill and give you a sensation of when it's ready to void, but give you the option to continue filling and defer voiding until a convenient time. When you arrive at the toilet, then the nervous system has to rejig things so that the bladder, the sphincters relax and the bladder contracts to bring about emptying. And then once the bladder is empty, then the process starts again. At this point, for your benefit, I'd also just like to point out that the bladder, whilst we talk about it becoming empty as a result of having been to the toilet, it is in fact not 100% empty. There is always a small amount of urine left in the bladder, which is why some people who are dealing with leakage sometimes can feel quite frustrated if they find that, well, I've just been to the toilet, but I still managed to leak. Surely I was empty. Maybe I wasn't. Anyone can leak at any time because the bladder is not 100% empty at any time. If we move to the central causes, this is where the control of that process is being mediated by what the brain is doing and what the nervous system, the spinal cord is doing. So toilet training, when children move from that process of having a bladder that fills up, decides I'm full enough, it's time to empty into the nappy, but to a point where it's no, I, the conscious thinking part of this person, am more interested in doing what I'm doing. And so I'm going to stay doing this activity, which means even though my bladder says, but I'm full, I'm comfortably full. Remember, it's not 100% full, but we're going to start telling the bladder to hold on. And then the nervous system works out how to keep juggling the situation and checking back with us until we, the thinking person, says, now's a good time to go to the toilet. I'll make my way there now. But whilst I'm making my way there, the bladder is still in its holding pattern. And so that's the higher order control system. And when things can go wrong for bladder control, then sometimes what you'll find is that the change has happened at the higher order end. So this is where people might feel like that it's all in their head. I didn't need to go to the toilet and now I'm suddenly busting. Why is that? And I would say, exactly, because your bladder is not demonstrably more full now compared to 5 minutes ago. So why have you gone from no sensation to a busting sensation? So there are situations in which the work we are doing as pelvic floor physios is about helping people to reorder how their nervous system interprets things. And we'll talk a bit more about that as we go on in the slides show. But it's for those reasons that I've put up on this slide that there are local and central mechanisms that we need to consider. When it comes to bowel health, if we look at the same sort of table, again, expectations about what's normal bowel function can be quite narrow in the community, depending on what your mother thought was normal or your father thought was normal. But essentially, a healthy bowel with a normal diet can be a bowel activity that can be as much as 1 to 3 times a day, or up to 3 days in the week, just once a day for 3 days of the week. And the variability there, we'll talk a bit more about on the next slide. In terms of storage and sensation, again, we're looking for the rectum to have a sense of comfortable fullness, being able to contain gas and solid stool. And if we're not able to have that experience, perhaps we're experiencing bloating, urgency, or pain with fullness, then we've got a continence issue. Again, emptying problems are usually the things that people are more aware of. And so continence would mean that we are able to manage to empty soft form stool at times of our choosing without strain or pain, and that an incontinence issue would be one where we are leaking gas or stool with or without straining and pain. But the other issues that people may not be so aware of is obstruction, where people are not emptying successfully. So this can happen for the bladder or the bowel, where the problem is that emptying is not effective. And so that is setting up some problems for that person. And poor stool form is a big contributor or component of an emptying problem. Similarly, there's a link at the bottom of the page for a bowel diary if these are things that you want to get a picture of your own situation. So if we move on to the next page, so here I've included a copy of the Bristol stool chart because this is probably the most relevant piece of information that I have to gain from clients when I'm working with them. And of course, it's not usually what people are expecting to come and talk to their physio about, but here you go. So if the stool consistency is not optimal, so in the middle, if we've got stool form like this, our continence mechanism tends to work pretty well without too many other issues. But our pelvic floor can be pretty healthy, but if we've got too soft a consistency, then we're going to have problems passing and clearing that. We may also find that we're vulnerable to leakage because the continence mechanism is designed to be optimal for this sort of form. So anything less than that is going to create potential problems for both effective emptying. So sometimes when people have this stool form, they're going back to the toilet 3 times a day because it won't all come out in one shot. Okay. So if somebody tells me that they go to the toilet 3 times a day and this is what they're passing, then I would consider that something to look at more closely. But if they're going 3 times a day and this is what they're passing, that's just their guts level of motility and activity. That doesn't have to be a problem at all. The one that people are often aware of is constipation. And, oh, sorry, I've gone the wrong way. Retract all of that. This was too, why is it saying too hard, too soft consistency? Oh, it's the chart that's wrong. I'm so sorry. This is the loose end that I was just speaking about. This is the hard end where the information is hard and lumpy. And so this is the constipated end and this is the loose end. So I'll need to change that slide for future reference. Okay, so constipation, where people have got a stool that is too hard or large, then the most common experience people describe with constipation is straining. They're having a difficult time emptying, okay? So if somebody is doing this 3 times a day, then I'd be concerned that they're constipated. If they were doing this 3 times a day, I'd be concerned that they've got a gut issue, which means that they're not getting an opportunity for normal stool formation, which is going to make control and emptying difficult. Okay. The other slide I've put up here, oh, sorry, go back. The other slide that I've put up is to illustrate for you where the muscle controls are in relation to the rectum. So there's a section of the pelvic floor that loops around at the base of the rectum and helps hold an angle between the rectum and the anal canal. And then we have layers of muscle around the anal canal itself. The inside layer is not within our voluntary control. It's an internal sphincter. But then we have an external layer of muscle that we can train. So this layer of muscle can be trained with exercise, and these layers, external anal sphincters, can be trained with exercise as well. I've put up the top here that commander, contents and conduit, those are the aspects of our mechanisms. So commander being the brain, contents being the diet, conduit being the intestines. They're the elements that will influence what sort of stool form we're going to get presenting at the other end. These 3, the container, the rectum, the canal being the anal canal, and control being the muscle elements. So these are the aspects of continence that are met by these structures here. Okay. So pelvic floor muscle training. Does pelvic floor muscle training treat these forms of incontinence? Yes, it does. So pelvic floor exercises are not going to address any of these issues: delirium, infection, vaginitis, psychological, pharmacological, endocrine, etc., etc. We're not going to change that with exercise, but if we as clinicians don't ask you, the client, about these sorts of things, then we may be sending you home with exercises that are of no use to you at all and missing the opportunity to get you to where you need to be. Similarly, we need to understand this pelvic floor exercises themselves is not going to change our stool form, but understanding stool form might give us an idea on why there may be some difficulties at the muscular level, how the control needs to be different. But if we need to change the stool form, then we're going to be going back to looking at those other issues. So this is where it becomes clear to me, and hopefully to you, that if you're working on a continence issue, you're going to have support and involvement from a doctor, possibly a pharmacist, possibly a dietitian, possibly a medical specialist that is geared to help look at these issues here. Medical specialists will also look at local factors to do with how the bladder performs. So that's where urologists might perform investigations to see how the bladder is performing. Colorectal surgeons and colorectal specialists may perform different tests to test how the rectum is working, plus also they can test for how the muscles are behaving during the process of emptying. So our specialists will have a role to play in all of these areas, but how does pelvic floor muscle training work? Well, at the clinic, we want to diagnose the problem so that we know what do we need our pelvic floor to do. Is it that we need the pelvic floor to provide more closure pressure, sit here at the rectum so that you're less likely to leak materials or gas? Are we needing the pelvic floor muscles to provide better support to the base of the bladder or to control the opening to the urethra? Are we needing to get the pelvic floor muscles to help calm down the central nervous system so that it stops trying to trigger a bladder contraction? And because the nervous system works in balance with each other, if you contract your pelvic floor, you close the pressure around the urethra, that automatically indicates to the nervous system that it needs to relax the bladder muscle. So there are relationships there that we can use to advantage. So teaching someone pelvic floor exercises is useful, but it has to be tailored to a diagnosis. And so a lot of the frustration people might have if they're attempting pelvic floor exercises at home is that what they're attempting isn't actually the right approach for exercise for their problem. And that's our role to help try and give you the information so that you can get to the right services and the right exercise program. Just going to go back a sec. So I'll go back a sec. Because of that specificity, if somebody has symptoms, continence symptoms, I'm not going to just give them a brochure. I'm not going to try and teach you pelvic floor exercises here tonight because I cannot tailor them for you. And this is, I hope you will then see that the benefit of pelvic floor exercises is only going to be achieved if it is done as a part of assessment and evaluation, and you need to be tailored in what you're doing. What about the people who don't have symptoms of incontinence but are just thinking about what about the future? I'm not incontinent, but I've got some mobility issues due to my arthritis. I don't want to get caught short. Well, unfortunately, if you look at the risk factors for pelvic floor muscle dysfunction and pelvic floor dysfunction that can lead to bladder and bowel issues, it's pretty hard to imagine an individual who can escape them. If nothing else, we've got aging, okay, which is why when you look at statistics, the number of persons experiencing incontinence increases with age, okay? And as we know, and when we have the running alongside that arthritis is a condition that can be a function of aging as well, then we've got these two things sort of travelling alongside each other until they perhaps converge. So in terms of if you are asymptomatic, it is still valid to say you need to exercise your pelvic floor muscles. It's a use it or lose it scenario. And if we think about what is our targeted health messages that you see in the community these days, a lot of it is about being fit for life. It's about strength training. And your pelvic floor muscles are another aspect of strength training that everyone should be considering as part of their approach to general well-being. Okay, but again, whether or not you need to be doing a 10-second contraction done 5 times or 10 quick contractions, all of those details are really determined by assessment. So again, if you are doing a gym program, then your trainer will assess, is she someone who needs to do bicep curls with a 5 kilo weight, or is she someone who really needs a 2 kilo weight at the moment? So specificity in exercise is always valuable, and with pelvic floor muscles, that is exactly the same. So I often end up using the adage that, you know, the one-size-fits-all approach generally fits nobody well. Okay, so if you're going to do it, let's do it well. Okay, but let's move on to some tips and strategies for people who are looking at how do I make choices to support functional continence. So functional continence is the ability to get to the toilet at the right time, okay? And the first thing is, so I've put up the home is where you trust the toilet seat. As just to set the scene that in the home environment, people who are dealing with mobility issues, they may end up making some decisions about changing bedrooms in order to be closer to the toilet if they've got an issue overnight. That if they've got upstairs toilet, downstairs toilet, thinking about accessing toilets in those regards, you're thinking about the layout of your house and what it takes for you to be able to use to get to that toilet. In terms of getting there, this is where sometimes people, I'll start with general exercise and pain management. If you've got arthritis, I'm sure you're aware that through exercise that targets your needs and pain management that manages your pain successfully, then that's going to result in better mobility. So you're going to be able to move to the bathroom with more comfort, more speed, more balance, so that as you're on your way, you're not at risk of losing control in the process. Okay. The other consideration is dress for success. This is where, again, sometimes the type of clothing that you might choose to use if you've got a continence issue could be worth considering, something that's easy to get on and off, particularly if your dexterity is starting to struggle, so your hands are having trouble with buttons and zips, thinking about those sorts of choices and maybe adapting your clothing. Continence products are also a valid choice for functional and social continence. So that's where you've got the backup of a pad or a product that you can wear, so that if you are unable to get to the toilet on time, then you've not had a leakage event that's caused you social distress. Okay. In the last page where we've got information about resources, there's also some details on how to choose the right continence product for your situation. Okay, and there are also financial resources available from the government to put towards the cost of continence products if you require them in an ongoing way. If it's a bowel issue, then sometimes what people might want to make use of is that there's the gastrocolic reflex, which is that when you eat, it starts your gut going, so you're more likely to have a bowel motion after food. There's also going to be a link to the Moo to Poo video. This is about how to empty your bowel effectively so that you are not being caught with material that's left behind that might result in smearing or soiling later. So there'll be a link to that. Just in case approach, which is the I'll just in case go to the toilet, and fluid manipulation, I'm going to leave for a little bit longer, but we will be dealing with it. If you're out and about in the public, then there's a terrific app for the National Public Toilet Map, which tells you where they are and what they've got. The other thing is that there's a campaign to increasingly have bins for blokes. So these are disposal bins in the male public toilets that are suitable for continence products, so that men who are using continence products have got somewhere to dispose of their product if they need it. Again, thinking about mobility aids, and this is where I know people may feel reluctant about using mobility aids at home or away. If you've got a continence issue, then if a mobility aid gives you more effective speed, balance and comfort, then it is worth using. But that mobility aid might be different depending on where you are. So it might be that a mobility aid is something that somebody uses not during the day at home, but they use it at night when they're waking up, because they're not necessarily moving as easily because they've been in bed stiffening up overnight. Maybe out in public, a mobility aid is of more value than it is using at home. So you make these practical decisions. The same issues for Dress for Success, but the other thing I'd add is take whatever hygiene products make you feel confident in a public toilet. Some people will squat or hover over a toilet seat in order to not be in contact with the toilet seat. Unfortunately, that is going to set up muscle activity in the pelvis that is likely to reduce the effectiveness you have for emptying. So it's better for you to take some wipes and wipe down the seat yourself and sit down properly, so that the nervous system has all the right cues to relax the sphincters, relax the pelvic floor muscles, so that you empty with success. Okay. All right. Okay, this slide is all about the just in case scenario. So the just in case scenario is that thought process that says, I'm worried that my bladder is going to be a problem to me whilst I'm away from home, is the first scenario. So I will go to the toilet just in case as I leave the house. And some of us were brought up by parents who always said, please go to the toilet before you leave the house, because the parent doesn't want to deal with it. The dilemma can become is that the environmental cue of I'm leaving the house or I'm going through the front door, whether it's going out or coming in, becomes an environmental trigger for the nervous system to say, oh, it's time to get that bladder going. This is the same conditional learning that was demonstrated by the famous Pavlov's dogs experiment. So Pavlov trained the dogs that whenever they heard a bell, they expected they were given food, and they were then trained so that whenever the bell was heard, they would start salivating in readiness for food. So the just in case strategy can be problematic. So we have to use it with caution. I generally say, if you know that a toilet is going to be available to you within 2 hours of leaving the last time you went to the toilet, then you don't need to just in case, because you can anticipate. If you're going for a walk around the block for 30 minutes and you went to the toilet an hour earlier, you're going to be home before your bladder should need emptying. Okay. So trust your capacity. And this is where, again, if you do a bladder diary, you'll get evidence of just how much your bladder is happy to hold, and perhaps start to have more confidence that, yeah, I can go for 2 hours between trips to the toilet. And so I don't need to just in case. But having said that, I'm just back from a trip to Melbourne, and I went to the toilet before heading off to the airport, and it was an hour and a half before the plane left, and I went to the toilet just in case, because I knew I was going to be on the plane for another hour, and I did not want to deal with a toilet in an aircraft. I had no sensation to need to go, but if I took myself to the toilet, sat down, gave all the right cues to my nervous system, I can have a wee. So we can use it strategically. Probably the most regular use of this is at bedtime. It is very appropriate signaling to your nervous system that you are getting ready for sleep, because you are going to the toilet, brushing your teeth, getting under the covers, turning out the lights. And some people will find that if their sleep is disturbed during the night, they may not be able to go back to sleep until they've gone to the toilet, because they need to reset the scene once more. So it's a useful skill, but just use it with caution. The other scenario is the situation where people may find that in the presence of running water, that their nervous system responds to those signals, and they then find that they'll have a wee in the shower. And they then find that when the tap gets turned on at the sink, the same noise and motion of water, now they want to go to the toilet before they can wash the dishes. When you are in a swimming pool, because you are immersed in water, if you're under the water, your kidneys are working faster, so you will fill up sooner, but you've just got to take yourself out of the pool and go to the toilet. Because regardless of what you think about whether or not the wee should be in the pool water, you're setting up your nervous system to expect water signals to be provocative of bladder contractions, and therefore an urge to go to the toilet. Okay, last one. Fluid management, fluid manipulation. So this is where we think about fluids and how they influence continence in terms of, are there problematic types of fluids, how much fluid is required, what's too much fluid, and perhaps the timing of fluid. So in the problematic list, artificial sweeteners are known to cause diarrhea. So if you've got a continence issue, you want to stay away from them. There's also a theory that the increase in irritable bowel syndrome is perhaps an unanticipated consequence of exposure to artificial sweeteners. And when we think about that, they are ubiquitous in so much of the diet-orientated food industry, there's certainly been population exposure on a massive scale. Carbonated drinks, so when the body's breaking those down, you end up with a type of acid being released. Carbonic acid is released, and some people do find that that is an irritating acid as to the their bladder lining. Alcohol is a diuretic and also can speed up the gut processes. So alcohol will certainly mean that the kidneys are working harder, producing more urine and softening your stool motion. So if you've got a continence issue, you may be making your life more difficult depending on how much alcohol you're having. And everyone's favourite preoccupation is caffeine. So caffeine is a challenge to our continence in two ways. One is it's a stimulant, so it gets the nervous system going and activates that part of the nervous system that is increases the desire to have a wee, to have a void. Okay, so this is a part of the stress hormone system response. It's also can be an irritant to the bladder lining. In terms of what's considered a healthy dose, a healthy daily amount of caffeine, so the Mayo Clinic says 400 milligrams of caffeine a day seems to be safe. And so they equate that, Mayo Clinic equates that to 4 cups of brewed coffee or 10 cans of cola or 2 of the energy shot type drinks. But as we know, the actual caffeine content in a range of these beverages can vary enormously. So proceed with caution. So in terms of problematic, it doesn't necessarily mean that everybody should eliminate all of those types of fluids, but they should consider how those fluids may be making their continence more challenging. And certainly for caffeine, sometimes what clients and I will work on is that they'll eliminate it for a time and then reintroduce it at a lower level so that they can feel socially normal once more. In terms of how much fluid, I've put down some ways to consider what's a normal amount. Our society is very preoccupied with water intake for a whole range of reasons that really don't have so much to do with health requirements, but more to do with supporting consumer industries. In terms of fluid, so these figures for how much fluid, whether it's water or juice or anything else, even some of those problematic ones, in terms of volume, we work it out based on your activity level and your body weight. So a person who's a sedentary person weighs 60 kilos, 1,200 mils of fluid a day can be fine. If they're more active, then it goes up to 35 mils. If somebody is doing exercise for 30 minutes, you would add roughly 360 mils per 30 minutes of exercise. And if you're breastfeeding or pregnant, then the additional fluid recommendation is between 720 and 960. That range reflects some weight-related issues, so the size of the woman concerned. So people will sometimes, if you do the calculation for your own body weight and your own lifestyle, people can sometimes be surprised that a tailored fluid load for you may not look anything like 2 litres a day. Okay, and in fact, there are scenarios in which too much fluid can be problematic to your health. If somebody has a urine output, so if we measure how much they wee and it's more than 2.5 litres, then that's going to warrant medical investigation because that's not normal. If somebody is drinking more than 1 litre an hour for more than 1 hour a day, they run the risk of water toxicity, which is where basically you're flushing your electrolytes away. And so that can then result in symptoms of confusion, delirium, nausea, and vomiting. It's actually very, very dangerous. But we also have to think about that for some individuals, they may have health concerns like kidney failure or heart failure, where they're going to be on fluid restriction. Whereas if you've got kidney stones, your doctor wants you to have more fluids than if you've got kidney failure. So again, it comes back to know what is a right fit for you. In terms of other fluid manipulation is to think about the timing of your fluids. So people who are having difficulty with waking to go to the toilet overnight, then it may be reasonable for that person to stop having their fluids 2 hours before their bedtime so that their kidneys start winding down. If caffeine is interfering with sleep, then that may also mean that it's harder to settle and you've got that irritant aspect to your bladder as well, interfering with sleep. So sometimes timing of fluids may be relevant. And so in your home environment or in your social environment, you may manipulate your fluid intake in these ways. Thinking about, do I want to eliminate problematic ones? Do I want to make sure that I'm not under drinking or over drinking? But I guess the other thing about timing, I've nearly forgot, is that what you need, that amount that you need on a daily basis, you don't have to have it spread out. So again, you can choose to have your fluids, your daily recommended amount. You can choose to have all of that before work and after work if your workplace is a place where you don't get to go to the toilet very often and you might just have a small quantity of sipping. So this is where nurses and teachers struggle with fluid intake because they don't get an opportunity during their work, let alone their opportunity for toileting. They really need to be able to go 4 to 5 hours before needing a toilet trip. So we might plan to shift their intake to before and after work. Okay, I think we got there. I went a bit longer than planned, so I won't talk about what's on this page, but I understand that this page will be made available to all attendees so that you can follow these links and check out the resources that I've mentioned so far. Right, thank you. I'm going to hand back to Ben, I think.
Thank you for that, Michelle. It was a fantastic, fantastic webinar and really, really informative. I think you covered a lot what people wanted and what people ask us about continence and arthritis, and it was a fantastic explaining everything. So, I mean, the question and answers are open if anyone has any questions, especially from the consumer side. We've got the first one. Someone's asking for the previous slides around if a person's consuming a lot of water and around 4 litres, would that 2.5 litres of urine output still warrant investigation?
No, it wouldn't. So it is something that, so it's a case of if they were having what was sort of if they were having a normal sort of fluid load for their body type and size, then no, that wouldn't be a concern. So it would only be a concern in that situation. Yep.
Perfect. And someone's on the same slide was asking if they're wondering things of like fruit juice and blended juices. Is that a bit of a difficult one because they're probably going to have those sweeteners in there and things like that?
Well, it depends. So this is where so fruit juice counts as fluid. So when I'm doing getting people to do a bladder diary, and my peers would say the same, is that anything that you would take in a glass or a cup counts as fluid. Okay, so sometimes the thicker smoothies, like if you really almost need to use the spoon at the end of the straw, then that's probably getting a bit more like a food. But again, I guess I should also say that fluid load in doesn't necessarily match urine output exactly, okay? Because all the food that we eat is also going to be broken down into fluid and carbohydrates and protein, etc. So what we take in glass or cup is not necessarily all our fluids, but the calculations that I've given you are all about what should we anticipate trying to have through a cup or a glass.
well,
Yeah.
from the overall level is, as you kind of said, and you, I mean, being a physio yourself as well, it's one of the things that we always talk about is about getting those right exercises for the right problems. And that's obviously in the pelvic floor and tonight. If people are starting really that exercise, I guess, journey and starting to increase their activity levels, could you predict changes to their continence? Would that affect that?
There is some evidence to suggest that in going from sedentary to active will facilitate improvement in continence. Okay. These are more observational references that have value when we're thinking about people living with dementia and people who are perhaps living in retirement nursing home settings, that environments that will support those individuals to be physically active as opposed to sedentary has also been shown to play out with a reduction in continence aid requirement. So by that, I mean that there are fewer incidences where the continence aid has been overflowed and increasingly more continence aids that are dry. Okay. And so there's no way that there's been any specific pelvic floor training for these individuals. So I would put this to the engagement of the pelvic floor muscles as part of the core postural control. So the more we are doing posturally based activity, active postural based activity means that we are using what we've got and thereby going from a sedentary level, building it up. But if we need to tailor the performance of the muscle to something more specific, like contracting in a timely fashion to prevent leakage with cough or sneeze, then general activity is not going to cover that.
Yeah, really well answered. I mean, it adds to the, I guess, the forever long list we've got of just how good being physically active and can help human beings as a whole.
Absolutely.
So, I mean, that's the questions we've had through. One of the ones that I'll ask from my end is that from the people you've seen, or if there's any research, is there higher levels of people living with chronic pain conditions like arthritis having those central, I guess, issues and things like that? Is there any linkage between there of people living with chronic pain?
The sensitized nervous system issues?
Yeah.
So are you referring to, so when people have got persistent pain, their nervous system starts to process information differently? That's what you're referring to? Yep. So there certainly is a lot of what we would call smudging, whereby if somebody's had an irritable bowel issue that has been about pain and through bloating or motility, that over time they may then develop a bladder pain issue as well. Now, the bladder on assessment may actually test up fine, but the nervous system is interpreting normal signals from the bladder as being yet another representation of the pain picture. So certainly there is crossover in that respect, particularly when it comes to other organs. So bladder, bowel, uterus, endometriosis, polycystic ovarian type conditions, they all tend to cross-populate with continence. There is some evidence to support that back pain can have can influence the development of pelvic pain as a central processing issue. Yeah. And certainly all the post-traumatic stress disorder scenarios are all may give expression to bladder symptoms, vaginal symptoms, bowel symptoms, gut symptoms. Absolutely.
Someone's asking if you can comment on the experience of being in a cold environment, e.g. getting out of a warm car on a cold night, triggering the urge to void the bladder. And then is this response being caused by the body's muscles contracting, or is it something else in response to that cold?
It's a really good observation. I don't have a proven article, a proven theory for it that I can reference you to. All I can say is that whilst you are in the water and immersion, that forces a lot of the fluids back to the center of the body. And so it's one of the reasons why blood pressure goes down, swelling in arms and feet will go down. But the flip side of that is that now your kidneys are producing more urine as a result. When you then exit the pool, you're going from a buoyant, no gravity environment to a gravity loaded environment. So for some people, if their pelvic floor musculature is not very supportive, then as they exit the pool, then their bladder is going to start to sit more low in the pelvis against a hammock, whereas it was sort of getting the benefit of buoyancy in the water. So that may trigger a sense of, oh, I'm fuller than I realized. And because of that, the brain may then say, uh-oh. And so then it becomes a top-down driven thing. So usually what I would suggest to people is that before you get out of the pool, switch your pelvic floor on and try and use those muscles to help carry you forth to gravity. So that's a bit of a loose interpretation. As far as cold goes, I still don't feel like I've been given a good enough explanation for why that we do have increased bladder sensitivity when we're in cold environments. But certainly people do report quite reliably that in winter their bladder's a little more troublesome than it is in summer. Okay, and there are a number of different possible explanations, but I won't go into it other than to say I don't know for sure.
Perfect.
Yep.
All right.
I've just seen a question that I would like to answer, which is about staying hydrated overnight. So just keep in mind, yes, a few sips before going to bed is fine, or having a glass bedside for a sip. But what we're looking for, but remember, overnight, you're not using fluids to the same degree either. Okay, so if you've got your hydration attended to through the day, you won't really need topping up overnight for hydration and cellular function, but you may find that it's a more comfortable thing, particularly if we sleep with our mouths open, we tend to get dry mouth. Okay. And the other question was about weather conditions. Again, there isn't a great, I haven't got a great reference for what we should do, other than I think you would then allow thirst to give you that information and rely on your sense of thirst to say, well, I must be utilising my hydration more quickly because of the climatic conditions I'm in. Okay. So yeah, I would let thirst dictate.
Really, really well answered to all of those, Michelle, and I really appreciate your expertise.